Welcome friends, welcome to Diabetes Rewired, a functional medicine approach to reversal and prevention. In this first lecture, I want to set the foundation for the entire course. If you understand this lecture well, everything that follows will fall into its place logically. So this lecture is not about drugs, it's not about diets, it's not even glucose numbers. It's about how to think about diabetes, because diabetes is not a single disease. It's a final common pathway of multiple interacting biological failures. I will repeat this line again for you. Diabetes is a final common pathway of multiple interacting biological failures, and unless we understand that clearly, we will keep chasing numbers instead of changing outcomes. By the end of this lecture, you should be able to answer 3 questions confidently. Why did diabetes develop in this person? Question number 1. Question number 2, why did it develop now and not 10 years earlier? And third one will be, and what does reversal realistic mean biologically and clinically? Why the conventional model of diabetes is incomplete? Let us begin by examining the model most of us we are trained in. In conventional medicine, diabetes is primarily framed as a glycemic disorder. We define diabetes using blood glucose thresholds. We classify severity using HbA1c, and we judge the success or failure almost entirely by these numerical targets. If HbA1c is high, treatment is intensified. If HbA1c comes down, treatment is considered successful. On the surface, this seems logical, but this model carries an unspoken assumption. This assumption is that hyperglycemia itself is the disease, and that assumption is fundamentally flawed. Glucose is not the disease. Glucose is just a biological signal. It's just like fever, tachycardia, or elevated CRP. Glucose elevation is the body's way of telling us that underlying regulation has failed. Lowering the signal does not necessarily correct the cause. This is why diabetes care often feels like running on a treadmill. We keep adding drugs, yet the disease keeps progressing. Let us look at a very common clinical trajectory. A patient is diagnosed with type 2 diabetes. Initially, the lifestyle advice is given and metformin is started. After a few years, HbA1c rises again, a second drug is added. A few years later, a third drug, then insulin. All the while, HbA1c may look acceptable on paper, yet complications they begin to appear. Neuropathy, microalbuminuria, fatty liver, cardiovascular disease, and this raises a critical question. If glucose lowering alone was not enough, why does disease progression continue even when HbA1c is controlled? The answer is uncomfortable but very clear. Glucose lowering treats a symptom, not the system failure. Large clinical trials have shown us this repeatedly. Intensive glucose lowering reduces microvascular risk to some extent, especially early time, but its effect on macrovascular outcomes is modest and very inconsistent. In some trials, aggressive glucose lowering has even increased mortality. I will repeat this phrase again. In some trials, aggressive glucose lowering has even increased mortality in high-risk patients. This tells us something very crucial. Hyperglycemia is not the primary driver of cardiovascular risk in diabetes. The real drivers, they lie upstream. Insulin resistance, hyperinsulinemia, ectopic fat accumulation, chronic inflammation, endothelial dysfunction, mitochondrial stress. These processes, they begin years before glucose rises, and by the time HbA1c crosses the diagnostic threshold, the disease has already been present silently for a very long time. So when we diagnose diabetes using glucose alone, we are diagnosing the late manifestation of a long-standing metabolic disorder. Another limitation of the conventional model is that it treats diabetes as a uniform disease. Type 1 is autoimmune, type 2 is lifestyle related. This binary classification oversimplifies reality. In truth, type 2 diabetes itself is deeply heterogeneous. Two patients with the same HbA1c, they can have different, completely different insulin levels, different fat distribution, different muscle mass, different liver involvement, different stress and sleep physiology, and different beta cell reserve. Yet, we often prescribe the same advice and the same medications, and this one size fit all approach is why many patients, they feel blamed, frustrated and confused. They are told to eat less and exercise more, yet their glucose doesn't improve. They are told that they are non-compliant when in reality intervention was mismatched to their biology. There is also a psychological consequence of glucose-centric model, this glucose-centric model. When glucose is framed as the enemy, patients become fearful of numbers. They chase perfection. They feel like failures when glucose fluctuates. This creates anxiety, guilt and burnout. Functional medicine reframes this completely. Instead of asking, how do we lower glucose? We ask, why is glucose rising? That single question changes everything. Functional medicine does not reject conventional medicine. It does not reject medications. It does not deny even the importance of glycemic control. What it does is put glucose back in its proper place. Glucose becomes a marker of metabolic stress, not the sole target of therapy. In this model, HbA1c tells us how overwhelmed the system is. Fasting glucose tells us about liver insulin resistance. Postprandial glucose tells us about the muscle function and beta cell capacity. I will repeat these three lines again for you. HbA1c, how overwhelmed the system is. Fasting glucose, about liver insulin resistance. PP glucose, postprandial glucose, about muscle function and beta cell capacity. So number becomes diagnostic clues, not moral judgments. This shift in thinking is the most important shift in this entire course. If you miss this, everything else becomes fragmented. And if you understand this, nutrition, exercise, medications, CGM and even supplements, they begin to make sense logically. So let us summarize this section 1 in one sentence. The conventional model focuses on glucose control, while the functional medicine focuses on restoring metabolic regulation. That is why functional medicine is not alternative. It is upstream medicine. In the next session, we will expand this idea further by looking at diabetes as a true systems disease involving multiple organs communicating with each other continuously. See you in the next session. Now that we have established why a glucose-centric model is incomplete, we can move to the next foundation of functional medicine. In functional medicine, diabetes is understood as a system-level disorder, meaning diabetes is not a problem of a single organ. It is the result of multiple organ systems communicating with each other and slowly losing coordination. The human body is an integrated network, and diabetes is what happens when that network becomes metabolic overloaded and dysregulated. To understand diabetes properly, you have to stop thinking only about the pancreas. Yes, the pancreas is involved, but the pancreas is often the organ that fails last. It is the final organ that can no longer compensate. The deeper story begins earlier and it involves multiple systems. the liver, skeletal muscle, adipose tissue, pancreas, gut, the brain, the endocrine system, the immune system, the circadian system, all interacting continuously every hour, every day. This is why the same diagnosis, type 2 diabetes, can look dramatically different in different patients, because the dominant failing system is not the same in everyone. I will repeat this line: the dominant failing system is not the same in everyone. Let us walk through each system briefly in a clinician friendly way, because this becomes your mental map for the entire course. First, the liver. The liver is the main organ that determines fasting glucose. Never forget that. It's not the pancreas, it's the liver. Fasting glucose, liver is the main organ that determines the fasting glucose. When the liver becomes insulin resistant, it keeps producing glucose even when insulin is high. Liver produces glucose. In insulin resistance, it's keep on producing glucose because it is resistant to the effect of insulin. That is why many patients, they wake up with an elevated fasted sugars. And in liver driven phenotype, diabetes is not primarily a problem of eating sugar. It is a problem of excess hepatic glucose output, often driven by fatty liver and insulin resistance. So fasting glucose is often a liver report card. Now, second will be your skeletal muscle. Skeletal muscle is the largest site of insulin mediated glucose disposal. Largest site of insulin mediated glucose disposal. Most of the glucose we clear after meals should be going into muscle glycogen, and when muscle become insulin resistant or when the muscle mass is low, either way, glucose clearance after meals become insufficient or inefficient. This is why sarcopenia, muscle loss, sedentary lifestyle, lack of exercise, and low muscle quality, it can drive postprandial hyperglycemia. Liver, fasting hyperglycemia. Muscle, postprandial hyperglycemia. In a muscle driven phenotype, the best medicine is often resistance training and increasing daily movement, because you are restoring the body's primary glucose sink. Liver is done, muscle is done, adipose tissue. Third, adipose tissue is not just storage, it's an endocrine organ. Healthy fat tissue can store energy safely, but dysfunctional adipose tissue, it becomes inflamed and spills fatty acid into circulation. This drives insulin resistance and ectopic fat deposition. So visceral fat is particularly harmful. The fat around our viscera or internal organs, intra-abdominal fat. Not inside the organs, but outside the organs and inside the abdominal cavity, because it drains into portal circulation and directly affects liver metabolism. So anything which our abdominal fat, the visceral fat produces, since it is going to drain itself, the blood supply is going to go into our portal system and into the liver. So it directly affects these cytokines which are produced, the inflammatory molecules which are produced by visceral fats, they are going to affect our liver directly, the liver metabolism. So adipose tissue biology determines whether calories are stored safely or become metabolic toxins. Fourth, the pancreas. The pancreas is the compensator. In early insulin resistance, the pancreas produces more insulin to maintain normal glucose, but this compensation has a cost. Over time, beta cells, they lose first phase insulin response, then they lose capacity. Then insulin deficiency begins to dominate. So diabetes is not just insulin resistance, it is insulin resistance plus beta cell failure. So I will repeat these 2-3 sentences. Over time, beta cells lose first phase insulin response. Then they lose their capacity. Then insulin deficiency begins to dominate. So it is insulin resistance plus beta cell failure, and and the rate at which beta cells fail varies widely between individuals. Fifth, the gut. The gut influences diabetes through multiple pathways. Incretin hormones like GLP-1 and GIP, bile acid signaling, microbiome metabolites like short chain fatty acids, butyrate and others, then intestinal permeability and endotoxin driven inflammation, appetite signaling and even satiety regulation. So the gut is not only about digestion, it is a major metabolic signaling organ. That is why meal timings, fiber, ultra processed food and gut health, they strongly influence glycemic control and insulin sensitivity. Now sixth, the brain. The brain regulates appetite, cravings, stress response, sleep patterns and circadian rhythms. So brain insulin resistance, if it happens, so the insulin resistance and reward circuitry dysregulation can drive overeating, preference for hyperpalatable foods and poor adherence, not because of weak willpower but because of altered neurobiology. I will again repeat, brain insulin resistance and reward circuitry dysregulation, both things, they can be a problem. So they can drive overeating, preference of hyperpalatable foods and poor adherence to a particular restricted diet, not because of weak willpower but because of altered neurobiology. The hypothalamus integrates leptin, insulin, ghrelin and stress signals. So the brain is not a passive observer, it's an active driver of metabolic behavior. Now seventh is our endocrine system. Diabetes is profoundly shaped by hormonal context. Cortisol increases glucose output and insulin resistance. Thyroid affects metabolic rate and lipid handling. Sex hormones influence fat distribution and muscle mass. Growth hormone affects insulin sensitivity. Menopause shifts body composition towards visceral fat, and PCOS is an insulin resistance syndrome. So the hormones can amplify or reduce the metabolic burden dramatically. Now eighth is our immune system. Chronic low-grade inflammation is not just an association, it is a part of the mechanism. Inflammation alters insulin signaling, worsens endothelial function and contributes to beta cell stress. So diabetes is, in many patients, also an inflammatory metabolic disease in many patients. And finally, the circadian rhythm. Circadian rhythm is not just sleep timings. It is a timing system that regulates insulin sensitivity, cortisol rhythm, appetite hormones, liver glucose output and post-meal glucose response. And if circadian rhythm is disrupted by shift work, by late night eating, sleep deprivation, glucose control worsens even without changes in calories. Shift work, late night shifts and sleep deprivation. So beware, these three things could cause diabetes. That is why the same meal eaten at 9 p.m. can produce a very different glucose response compared to the same meal eaten at 9 a.m. Now when you see diabetes as a systems disease, a major clinical truth becomes obvious. Two patients with the same HbA1c can be metabolically completely different. Patient A may be severely insulin resistant with very high insulin levels. This is often a visceral fat and fatty liver dominant phenotype. Their main issue is not the lack of insulin. Their main issue is insulin overload and resistance. And patient B may have relatively low insulin level for their glucose, meaning the beta cell is failing. They are insulin deficient and their problem is not only resistance, it is the loss of insulin capacity. And patient C may just have fatty liver as the central driver, and patient D may have sarcopenia and low muscle mass as the dominant driver, and patient E may have sleep deprivation, chronic stress and cortisol excess as the dominant perpetuator. Same diagnosis, very different biology. And here is where functional medicine becomes clinically powerful. The first shift we must make is this: diabetes is not a single diagnosis, it is a phenotype. The phenotype is what you see at the surface: elevated glucose, elevated HbA1c, sometimes obesity, sometimes not, but underneath the phenotype are multiple possible pathways, and the pathways matters because the pathway determines what will work. If you treat all phenotypes with the same intervention, you will get inconsistent results. If you identify the dominant pathway, you can personalize care. That is why phenotyping becomes a core skill. You start asking questions like, is glucose high or are post meal spikes dominant? Is fasting insulin high or low relative to glucose? Is triglycerides high and HDL low, suggesting hepatic insulin resistance? Is ALT, SGPT elevated or ultrasound showing any fatty liver? Is muscle mass low? Is strength low? Is activity low? Is the patient sleeping 5 hours and eating dinner at 10 p.m.? Are they on steroids, antipsychotics or other diabetogenic drugs? Do they have features of PCOS or endocrine dysfunction? Is there a possibility of LADA? These questions move you from treat diabetes to treat this patient's diabetic biology. So let me summarize this section 2 in a way you remember. Diabetes is not a disease of blood sugar, it is a disease of metabolic network dysfunction. Your job is not only to lower glucose, your job is to find which part of the network is failing first and most strongly. And that is the foundation of personalization. In the next section, we'll take this system understanding and apply it to a practical clinical tool, the functional medicine matrix of antecedents, triggers, mediators, and perpetuators. Now that we understand that diabetes is a systems disease, the next question is practical. How do we organize our clinical thinking so we don't get overwhelmed? Because when we start looking upstream, there are many possible causes, many possible pathways, and many possible interventions. And functional medicine solves this problem with a simple but powerful framework: antecedents, triggers, mediators, and perpetuators. So this is sometimes also called as functional medicine matrix, and I want you to treat it just like a clinical checklist. I will repeat these 4 words: antecedents, triggers, mediators, and perpetuators. When used properly, it prevents 2 common errors. Error number 1, treating everyone with the same protocol, and error number 2, treating only the lab values rather than the patient. So let us apply the matrix directly to the diabetes. Antecedents, the terrain. Antecedents are the terrain, the background factor that create vulnerability. They are not cause disease by themselves. They don't cause disease like that, but they determine how much stress the system can tolerate before it breaks. In other words, antecedents explain who is at risk. Let us list common antecedents you will see in clinical practice, like family history of diabetes, type 2 diabetes if there is family. This often reflects inherited beta cell vulnerability, insulin resistance tendency, or fat distribution patterns. Then history of gestational diabetes, that is also one of the antecedents. This is one of the strongest predictor of future type 2 diabetes and is often a sign that the metabolic threshold is already very low. Then PCOS. PCOS is not just a reproductive disorder, it's an insulin resistance syndrome. And many PCOS patients are pre-diabetic long before glucose rises. Ethnic susceptibility. South Asians, for example, often develop diabetes at lower BMI due to higher visceral fat and lower muscle mass. Other populations have their own risk patterns. Low muscle mass from early life is another antecedent. This is often overlooked. If a person grows up sedentary, under protein and never builds muscles, their capacity for glucose disposal is reduced for life. Early life stress and trauma. Chronic early stress can affect cortisol regulation, autonomic tone, sleep and inflammatory biology, creating vulnerability later. Then another antecedent, you can say poor sleep patterns established for decades. If someone has been sleeping 5 to 6 hours for 20 years, their insulin sensitivity is often impaired long before they have become diabetic. Then long-term steroid exposure or recurrent steroid bursts. If glucose is normal today, the metabolic vulnerability is higher, even if the glucose is normal today. Understand that. Environmental toxin burden and endocrine disruptors. It's also a very important antecedent. There is a more complex, this is a very complex area or a region, but the key functional principle is that chronic exposures may contribute to mitochondrial stress, inflammation and endocrine dysregulation in susceptible individuals. So antecedents are your background map. They tell you this patient has a lower threshold, but this is very important, antecedents alone do not create diabetes. Many people have antecedents and never develop diabetes. That brings us to the next layer, and it is triggers. Antecedent and first layer, antecedent. Second layer is triggers, crossing the threshold. Triggers are the events or the changes that push the system past its threshold. Triggers explain when diabetes appears. So this is one of the most clinically useful ideas, because patients often they ask, doctor, why did I suddenly become diabetic this year? And triggers are they are often the answer. Common triggers include like rapid weight gain. Even 5 to 10 kg of visceral fat can shift insulin resistance dramatically. Pregnancy is a physiological insulin resistant state, we know that, and in vulnerable persons it can unmask future diabetes. Menopause is a metabolic transition, so loss of estrogen specifically shifts fat to the visceral compartment and reduces insulin sensitivity. Then chronic psychological stress. So stress increases cortisol and sympathetic tone, along with it drives higher glucose output and insulin resistance. Shift work or night duty is also a trigger. So circadian disruption is a major trigger, especially when paired with late night meals. Sleep deprivation, not just insomnia, sometimes new sleep apnea or new job schedule or caregiving demands, it also could be a trigger. Then major illness like severe infections, COVID, hospitalization, surgery, these can unmask diabetes by increasing inflammatory and stress pathways. Then prolonged inactivity, an injury, a new sedentary job, stopping exercise. This can reduce muscle glucose disposal and shift the balance towards development of diabetes. Then dietary transition to ultra processed food also could be a trigger of development of diabetes with the precedent. Sometimes it is not just more food, but a change in food quality, refined carbs, sugary beverages or packed snacks. Then excess alcohol. Alcohol can worsen fatty liver, raise triglyceride, disrupt sleep and push insulin resistance. Then long-term medications like steroids or antipsychotics. Yes, and sometimes even repeated courses of steroids for asthma or joint problems can also cause diabetes. So when you identify triggers, you can often pinpoint the moment the metabolic system crossed from compensation to failure. And that helps patients understand that diabetes is not a sudden moral failure, it is a threshold problem. Now, third one is mediators. That is, what is driving the disease now? So now we come to the most actionable layer here, where we can intervene most is mediators, they are active mechanisms causing symptoms as on today. This is where biochemistry and pathology enter. So mediators answer the question, how is the disease operating right now in this patient? Here are the most common mediators in type 2 diabetes. Hepatic insulin resistance. The liver continues to produce glucose despite insulin. This drives high fasting glucose and a strong down phenomenon. And then muscle insulin resistance. So skeletal muscle, as I discussed in the previous section, they fail to clear glucose efficiently, and this drives postprandial spikes and persistent hyperglycemia after meals. Visceral adipose inflammation. Inflamed visceral fat releases cytokines and free fatty acid. They go to the liver and they worsen insulin resistance and feeding fatty liver. Ectopic fat accumulation in liver and pancreas. Fat in the liver drives insulin resistance. Fat in the pancreas correlates with beta cell dysfunction in many patients. Then mitochondrial dysfunction and impaired metabolic flexibility. The body becomes poor at switching between fuel sources, leading to fatigue and cravings and reduced exercise tolerance. So because body is not able to switch between fuel sources. So because of mitochondrial dysfunction, the two main fuel sources are either it would be glucose or it will be ketone bodies. Oxidative stress and glycation stress. This is a part where complications begin even before diabetes is severe. Then chronic cortisol elevation. This increases hepatic glucose output. It worsens insulin resistance and disrupts sleep and appetite. Incretin dysfunction, GLP-1 and related pathways. They influence insulin secretion, satiety and post-meal glucose control. They influence insulin secretion, satiety and post-meal glucose control. So incretins, never forget them. They are being used left and right nowadays as for weight reduction and diabetes control. Gut dysbiosis and gut liver axis dysfunction. This can contribute to inflammation, insulin resistance and appetite dysregulation. Now here is the key clinical point. Different patients have different dominant mediators. Two patients can have the same HbA1c but different mediators. If the dominant mediator is the fatty liver, you need a liver focused strategy. If the dominant mediator is sarcopenia, you need a muscle first strategy. And if the dominant mediator is cortisol and sleep, you need circadian and stress first connection. This is why functional medicine is fundamentally about mechanism based personalization. Now the fourth one is perpetuators. What is preventing recovery? Finally, perpetuators are the factors that keep the disease going even after the trigger has passed. So perpetuators, they explain why does diabetes persist despite treatment? Why is the patient not improving and why does relapse happen? So common perpetuators, late night eating. Even with healthy food, late timing worsens glucose response and increases liver fat deposition risk. So sedentary lifestyle, then yes, there is also a perpetuator. Not just no gym but too much sitting throughout the day. Then poor sleep and untreated sleep apnea. Sleep apnea is one of the most underdiagnosed perpetuators of insulin resistance. Mark this line, sleep apnea. Even thin individuals can also have sleep apnea. Ongoing stress without recovery, high cortisol and sympathetic tone becomes chronic. Alcohol excess. Even moderate daily alcohol in some patients sustain fatty liver and sleep disruption. The low protein intake, especially in our country, India, this contributes to sarcopenia, poor satiety and worse glucose disposal capacity. Loss of muscle mass, especially with aging. This is a major perpetuator in older patients and in lean diabetes. Social environment and food environment. If the household eats ultra processed food daily, the patient's plan will collapse. It cannot sustain. So unrealistic diet plans plans that are too strict, too complex or culturally incompatible, that will lead to non-adherence and they will rebound. So that is also one of the perpetuators. The lack of monitoring and feedback. If the patient doesn't see cause and effect, like post-meal glucose patterns, if you are not very cautious about what to monitor, what to tell your patients to monitor, they could miss actually even healing signs. They often lose motivation. So this is also important. So they have to be kept motivated by proper monitoring and proper feedback. Then medication side effects. Some medications, they drive weight gain, fatigue or hunger, making lifestyle they change a little harder. Now in functional medicine, perpetuators are not blamed on the patients. They are treated as clinical variables. If sleep is a perpetuator, we treat sleep. If sedentary time is a perpetuator, we prescribe movement. If low protein is a perpetuator, we correct nutritional structure, and if stress is a perpetuator, build recovery systems. Why this matrix matters, these four things which I told you. This framework is crucial because it tells you what to target. Traditional care often targets the downstream glucose. Functional care targets the mediators and perpetuators. Because if you reduce mediators and remove perpetuators, glucose improves as a downstream consequence. So let me give you a simple way to use this clinically. Ask 4 questions in every diabetic patient. Number 1, what made this person vulnerable? Antecedent. This is antecedent. Number 2, what pushed them over the edge? Triggers. What was the trigger? Number 3, what is driving the dysglycaemia right now? Mediators. What are the mediators? And 4th one, what is stopping recovery today? Perpetuators. All 4. You must have all these 4 answers in all patients on an individual basis. When you can answer these 4 questions, your treatment becomes logical and individualized, and you stop practicing trial and error. You start practicing cause-based medicine. In the next section, we'll take this matrix and translate into real-world clinical phenotypes so you can recognize patterns quickly and personalize intervention with confidence. Now, let us talk about heterogeneity, because this is where functional medicine becomes immediately practical. In real life, type 2 diabetes does not behave like one disease. It behaves like multiple diseases that share a final common outcome, elevated glucose. And that's why treating type 2 diabetes as a single uniform condition produces inconsistent results. Because what we call type 2 diabetes is often a label placed on many different biological patterns. So in clinic, the question is not only does this patient have diabetes? The more important question is what kind of diabetes physiology does this patient have? Or which mechanism is dominant? Or which organ system is failing first? That is what we mean by phenotyping. Let us walk you through common phenotypes that you will see repeatedly in practice. As I described each one, I want you to visualize real patients from your own clinic, because once you see these patterns, you will never unsee them. Phenotype 1, liver dominant insulin resistance. These patients, they typically present with central obesity, especially abdominal obesity, fatty liver on ultrasound, or an elevated ALT and AST, high triglycerides often with low HDL, high fasting glucose, high fasting insulin, high HOMA-IR, and sometimes acanthosis nigricans. And in these patients, fasting hyperglycemia is often the dominant feature. Their post-meal spikes may be present, but the hallmark is the fasting problem. And the biology is very, very simple. The liver continues to produce glucose despite insulin. And so when insulin is high, hepatic glucose output remains high. This is hepatic insulin resistance. And a common clue is a strong dawn phenomenon. Glucose rises early morning even with no food intake. Now, here is an important clinical insight. Many liver dominant patients will not improve significantly if you only focus on avoid sugar, because the liver is making glucose internally. The most powerful lever here is reducing hepatic fat and improving hepatic insulin sensitivity. So, the strategy often includes weight loss with attention to liver fat reduction, carbohydrate quality and timings, alcohol reduction, fructose reduction, fruit reduction, honey reduction, post meal walking, sleep correction, and appropriate medication that target hepatic glucose output and insulin resistance. So, this phenotype responds very well when you treat the liver as the center of the problem. That was phenotype number 1. Phenotype number 2, muscle dominant insulin resistance. These patients, they are missed because they may not look typically diabetic. They may have normal BMI or only mild overweight, low muscle mass or low strength, a sedentary lifestyle, high sitting time, large post meal glucose spikes, relatively normal fasting glucose early, and sometimes normal triglycerides and only mild fatty liver. In these patients, the problem is not mainly hepatic output, the problem is glucose disposal. Skeletal muscle is the main sink for glucose after meals. This is the main organ which is going to control postprandial hyperglycemia. So, if muscle is insulin resistant or if muscle mass is low, glucose remains in circulation longer after meals, producing spikes and prolonged hyperglycemia. And in older patients, this phenotype is extremely common. Don't forget that. And it is one of the reasons lean diabetes becomes more common with age. And now, here is what makes this phenotype powerful. It often responds dramatically to resistance training, improving muscle quality, increasing daily movement, reducing sedentary time, and adequate protein intake and post-meal walks. So, in muscle dominant diabetes, exercise is not just advice, exercise is primary treatment. So, because you are restoring the body's physiological capacity to clear glucose. Okay. Phenotype 3, beta cell failure dominant. This phenotype is critical because it changes your risk and urgency. These patients, they often have longer duration of diabetes, marked postprandial hyperglycemia, then rising HbA1c despite multiple oral agents, then poor response to lifestyle changes alone, then sometimes weight loss despite hyperglycemia, and a strong family history of diabetes, and sometimes a history of early diagnosis at a younger age. And in these patients, insulin resistance may still be present, but the key issue is the insulin secretion is insufficient for the degree of demand. So, beta cell failure is becoming dominant, and they have lost first phase insulin response after meals. So, post meal spikes will become prominent and difficult to control. Now, this is where many clinicians, they will make an error, understand that. They keep escalating glucose lowering agents without addressing beta cell stress. But if glucotoxicity and lipotoxicity continue, beta cell failure accelerates. So, these patients, they require a strategy that focuses on reducing glucose toxicity quickly and safely, reducing insulin demand, avoiding repeated high glucose excursions, and preserving remaining beta cell function, and sometimes earlier use of therapies that reduce beta cell workload, and if needed, early insulin support, not as failure but as beta cell protection. The functional medicine approach is still valuable here, but if you must be realistic, remission potential depends on remaining beta cell capacity, and the patient counseling must be honest. Okay, so phenotype 4, stress, sleep, circadian driven diabetes. This is a phenotype that standard protocols they often ignore, and these patients, they typically have shift work or night duty, insomnia or poor sleep quality, late dinners and late night snacking, high perceived stress by them, anxiety or burnout, prominent down phenomenon and erratic glucose patterns despite good diet. In these patients, the dominant driver is not only food, it is neuroendocrine physiology. Cortisol increases fatty glucose output. Sympathetic activation reduces insulin sensitivity, and sleep loss increases insulin resistance and appetite hormones. Circadian misalignment alters the timing of insulin sensitivity. So, the same meal produces a higher glucose response at night than in the morning. That you must not forget. And this phenotype requires a different kind of intervention. You must address sleep duration and sleep quality. Sleep apnea screening is indicated. Circadian meal timing, stress regulation strategies, morning light exposure, exercise timings, and realistic routines for shift workers. And in these patients, if you ignore sleep and stress, dietary changes, they often fail. And if you fix circadian biology, glucose can improve even without extreme dietary restrictions. Don't forget that. Phenotype 5, medication or endocrine driven dysglycaemia. So, this phenotype is crucial because it may not be lifestyle diabetes, and common contributors like steroids, systemic or repeated bursts of steroids when we give, Cushing syndrome or chronic cortisol excess, thyroid dysfunction, PCOS, menopause related visceral fat shift, obstructive sleep apnea, antipsychotics and other weight promoting medications, and sometimes chronic pain medications even, and inactivity secondary to pain. The clinical approach here begins with one question: what is the driver? If steroids are necessary, you cannot remove the driver completely, but you can anticipate and mitigate. If sleep apnea is present, treating it can improve insulin sensitivity and reduce glucose variability. If PCOD or PCOS is there, insulin resistance management is central. If menopause has shifted the body composition, resistant training and protein strategy becomes even more important. The key point here is, when diabetes is medication or endocrine driven, you must plan, your plan must include addressing that driver, not only diet advice. Now, mesquenders here, a couple of words about that. LADA and other non-type 2 diabetes pattern. Now we come to a critical warning: not every adult with high glucose has type 2 diabetes. The most common mesquender is latent autoimmune diabetes in adults, LADA. These patients are often lean or mildly overweight. They are adults. Either they will be lean or just mildly overweight, and they are diagnosed in adulthood, but they progress very rapidly and poor responders to oral drugs. Early insulin requirement they will have, and sometimes they will lose weight unintentionally, and often they have personal or family history of autoimmunity like thyroid disease, vitiligo, rheumatoid conditions. So, mistaking LADA for type 2 diabetes is dangerous, because denying insulin in an insulin deficient patient increases the risk of severe hyperglycemia, ketosis and faster beta cell loss. Always understand, in insulin requiring patient, giving insulin is bioidentical hormone replacement. So, from the very first visit, you must keep LADA in your differential, especially in lean patients or rapid progressors. Why phenotyping matters from the first visit? So, let me bring this back to the main point. From the very first visit, phenotyping matters because it tells you which levers will work fastest, which risks are greatest, and how realistic remission is, and how to counsel the patient properly, how to avoid dangerous errors like missing LADA. And phenotyping does not require complicated tests at first. It starts with simple clinical observation: fasting versus post meal patterns, body composition and waist circumference, triglycerides and HDL, ALT and fatty liver clues, muscle mass, strength and activity level, sleep patterns, stress load, shift work, and medication history and endocrine symptoms, and rate of progression and family history. So when you see diabetes through these phenotypes, treatment becomes logical, personalized, and far more effective. In the next session, we'll talk about what reversal actually means, because once you understand phenotypes, you understand why reversal is possible in some patients, partial in others, and not realistic in a few. What does reversal actually mean? Now let us address one of the most misunderstood and most emotionally charged words in diabetes care: reversal. Patients hear reversal and they often imagine a cure, a permanent reset, a situation where they can return to the old habits without consequences. So we have to be very precise, both scientifically as well as ethically. Reversal does not mean cure. Reversal does not mean permanent immunity. Reversal does not mean diabetes can never return. What reversal does mean, when used correctly, is this: restoration of metabolic control without ongoing glucose lowering medication, as long as the improved physiology is maintained. In scientific language, we call it remission. Remission is a better term because it automatically reminds of an important truth. Remission is a controlled state. It's a state where it can be maintained and it can also relapse. Now, clinically, patients move through levels of improvement, and it helps to name them clearly. First level, improved control. Glucose improves, HbA1c comes down. Often this happens with lifestyle change plus medications or with fewer medications than before. Second level, partial remission. HbA1c falls below the diabetic range, but the patient may still require minimal support. Sometimes metformin or another low risk medication depending upon your clinical approach. Third level, remission. HbA1c remains below the diabetic threshold without glucose lowering drugs for sustained period with continued monitoring. Now this part is crucial. The word remission is not just a motivational label, it is a biological statement. It means the patient physiology has shifted into a state where the metabolic system is no longer overwhelmed. And here is the most important principle of this course: remission depends upon biology, not belief. It depends upon physiology, not motivation alone. It depends upon duration of disease. Earlier disease usually has better remission potential because beta cells are less exhausting. Second, residual beta cell activity. If the beta cell is severely depleted, lifestyle alone cannot replace insulin secretion. In that case, our goal becomes optimal control and complication prevention, not unrealistic promises. Third one will be degree of ectopic fat, especially in liver and fat. In many patients, reducing ectopic fat is a key step in restoring insulin sensitivity and beta cell responsiveness. And fourth one will be degree of insulin resistance. Severe insulin resistance requires larger changes and longer time frames. And finally, ability to sustain lifestyle changes, not perfect lifestyle, sustainable lifestyle. Because even if a patient reaches remission, relapse can occur if upstream drivers return: weight regain, visceral fat, sleep disruption, inactivity, or chronic stress. That is why early diabetes is generally more reversible than late diabetes, and that is why promising reversal to every patient is unethical. It creates false hope. It also can lead to medication abandonment, and it can damage trust when remission does not happen. So functional medicine must be optimistic but honest, and we tell patients improvement is very likely. Medication reduction is often possible. Remission is possible in selected patients, especially elderly, and our job is to maximize your physiology safely without overpromising. This is the correct evidence-aligned way to use concept of reversal, and it sets the tone for everything that follows in this course. Now let me summarize type 2 diabetes in simple, clinically useful terms, because if you can explain this clearly, you can teach it to the patients and you can also choose interventions more logically. Type 2 diabetes develops when insulin resistance rises and the beta cells can no longer compensate. In the early stage, insulin resistance begins quietly, often in liver and muscle. To keep glucose normal, the pancreas responds by making more insulin. So for a long time, patient may have normal glucose but high insulin. That stage is often labeled pre-diabetes or insulin resistance, but biologically it is already diabetes physiology in motion, just still compensated. Over time, chronic high insulin demand creates stress on the beta cell. The beta cell begins to lose efficiency. The earliest functional change is usually loss of the first phase insulin response, the rapid burst of insulin that should occur immediately after eating. When the first phase insulin is lost, post-meal glucose rises first. So in many patients, the first visible abnormality is postprandial hyperglycemia, even when the fasting glucose is still relatively normal. As the process continues, hepatic insulin resistance becomes more established and fasting glucose begins to rise as well, because the liver keeps producing glucose overnight and in between meals. So the pattern often moves from normal fasting glucose with post meal spikes to elevated fasting glucose to persistent hyperglycemia throughout the day. At the same time, high glucose and high fatty acids, they create a toxic environment for beta cells, and that is what we mean by glucotoxicity and lipotoxicity. High glucose impairs beta cell function and insulin secretion. High fatty acids and atopy fat increase cellular stress and worsen insulin signaling. So together, glucotoxicity and lipotoxicity, they accelerate beta cell failure and deepen insulin resistance. That is why waiting with uncontrolled glucose is harmful, because it is not just a number, it is ongoing metabolic injury. So the functional medicine goal becomes very logical. Reduce insulin demand so the beta cells is not forced to overwork. Improve insulin sensitivity, especially in liver and muscle, through nutrition, movement, sleep and targeted pharmacology when needed. Then preserve remaining beta cell function by reducing glucotoxicity, reducing ectopic fat and preventing repeated glucose spikes. When you keep this core pathophysiology in mind, lifestyle and medication choices are no longer random. They become mechanistically aligned, and this is the biological logic behind this entire goal. So what improves first when the treatment is right? Patients almost ask a very practical question, Doc, how soon will I see the improvement? And this is not a small question. Understanding timelines is critical for adherence, because if patients expect everything to change in 1 week, they will drop out. And if they expect nothing to change for 6 months, then they will also lose motivation. So we need to teach them a realistic sequence of improvement. First, post-meal glucose usually improves the fastest. Often within days to a few weeks, you can see meaningful changes in postprandial spikes, and this is especially true when we adjust meal composition. More proteins, more fiber, lower refined carbs. Meal sequencing, vegetables and proteins first, then only starch, and post-meal movement like 10 to 15 minutes walk after meals. And CGM makes it very obvious. Patients can literally see cause and effect, which is highly motivating. Second, fasting glucose improves more slowly. So fasting glucose is largely the reflection of overnight liver glucose output, hepatic insulin resistance, and in many patients fatty liver. So fasting glucose often needs weeks or months to improve substantially. That is why a patient may say, Doc, my after meal sugars are better, but my morning sugar is still high. This is normal in many cases. It often means the lifestyle changes are working, but the liver physiology is still catching up. Third is HbA1c. It takes time. HbA1c is a backward looking marker. It reflects the average glycemia over approximately or previous 8 to 12 weeks. So if a patient changes today, the HbA1c will not instantly reward them. That is why we use short-term feedback like CGM patterns or SMBG trends. So patients stay engaged while HbA1c lags behind. Fourth one, deeper metabolic changes take months. Weight loss, visceral fat reduction, improved fitness, muscle gain and metabolic flexibility are not 1 week projects. They develop over months and they are what determine long-term outcomes and durability. And then if remission is possible for that patient, we typically assess it over months to a year with continued monitoring and safety first medication adjustments. So the clinical takeaway is simple. When patients know what improves first and what takes longer, they stop panicking and they stop quitting early and they stay consistent. Setting realistic expectation is not just counseling, it is a core part of our treatment. So this section, let us discuss about safety first philosophy. Now we come to something that must be repeated again and again in functional diabetes care. Functional approaches can lower glucose rapidly. That is a good thing because it means physiology is improving, but it also means we must be extremely careful because rapid improvement in glucose can become dangerous if medications are not adjusted properly. The highest risk situations involve medication that can cause hypoglycemia. The two major categories are insulin, especially when basal, bolus or mixed insulin regimes, and sulfonylureas, and sometimes meglitinides. When diet changes reduce carbohydrate load and when activity increases glucose uptake, these medications can suddenly become too strong for our new physiology. And hypoglycemia is not a minor side effect. It's a medical emergency risk. Falls, accidents, arrhythmias, cognitive impairment, and in severe cases, even seizure and death. So functional medicine must be safety first and not the ideology first. Here is the practical rule. Whenever you significantly change any of these like diet composition, especially carbohydrate restriction, meal timing, especially intermittent fasting or time restricted eating, exercise volume or intensity, weight changes that affect insulin sensitivity or sleep and stress patterns that alter glucose variability, then medications must be reviewed and monitoring must increase temporarily. That might mean more frequent SMBG or preferably continuous glucose monitoring CGM or structured pre and post meal checks for a few weeks, especially during the transition period. Another safety point that clinicians often sometimes forget is when glucose improves rapidly, patients often feel empowered and they might decide on their own to stop medications. So we must educate them clearly, like never stop insulin or sulfonylureas abruptly without guidance, or report low readings immediately. And if you are fasting, you need a specific plan. Education prevents dangerous self-experimentation. Now let me say this clearly because it is the ethos of this course. Functional medicine does not replace conventional medicine. It does not compete with evidence-based pharmacology. It does not promote medication avoidance as a badge of honor. Functional medicine integrates with conventional care. It uses lifestyle, sleep, stress, nutrition and movement to reduce the upstream disease load while using medications intelligently for safety, symptom control and complication prevention. And throughout this process, the highest priority is not reversal. Highest priority is patient safety, stability and sustainable improvement. This safety first mindset is what makes functional diabetes care both effective and responsible. What this course will and will not do. Let me be very clear. This course will not give you a single diet plan for all patients. It will not promote ideology. It will not encourage medication abandonment. What it will do is to teach you how to think mechanistically, how to phenotype patients, how to choose interventions rationally, how to combine lifestyle and pharmacology intelligently, how to speak honestly about remission, how to prevent complications proactively. So in this first lecture, I want you to take away one idea. Diabetes is not a failure of willpower. It is not simply a disease of sugar. It is a disease of metabolic overload interacting with human biology. When we respect that biology, remarkable improvement is possible. In the next lecture, we will go deeper into etiology and systems biology of dysglycaemia, explaining why modern environments push human metabolism beyond its design limits. Thank you.